Welcome back, coders. I'm Harshal, and you're tuning in to Part 9 of our 100-part CPC exam series. Today, we're conquering the respiratory system. We're going to break down tract divisions, lung lobes, and those absolutely crucial procedure clues straight from the 2026 CPC study guide. But hey, before we start decoding these airways, make sure to like, share, and subscribe to Decode Healthcare with Harshal. All right, let's dive right in.
So why does respiratory anatomy actually matter when you're staring down a multiple-choice coding question? Well, because on the CPC exam, precision is literally everything. Localizing a pathology, pinpointing it by its specific lobe, its airway level, or whether it's trapped in the pleural space, that's not just medical trivia. It is the exact mechanism driving your CPT and ICD-10 code selection. If you misjudge that anatomical depth by even a fraction, boom, you pick the wrong code. And in the real world of medical billing, that translates instantly to a denied claim or, worse, a failed audit. Understanding this terrain is your ultimate defense.
Think of the respiratory system like a top-down journey of a single breath. We divide this anatomical map into two main tracks. And this is crucial, folks, because upper tract codes are often grouped entirely differently in your CPT manual than the lower tract surgical codes. So the upper tract, that includes the nasal cavity, the pharynx, which actually breaks down into the nasopharynx, oropharynx, and laryngopharynx, and the larynx, which is your voice box housing the vocal cords. Basically, this upper section is what warms and filters the incoming air. Then, as we move below that, we hit the lower tract. This includes the trachea, the bronchi and bronchioles, acting as your conducting airways, and finally, the alveoli. Those are the microscopic sacs that are entirely responsible for gas exchange.
Now listen up, because right here is a massive, high-yield exam trap that catches countless coders totally off guard. The lungs, they are not symmetrical. Nope, the right lung actually has three distinct lobes, superior, middle, and inferior. But the left lung, it only has two lobes, the superior and inferior, plus this little thing called the cardiac notch to, make room for your beating heart. This is absolutely huge for your exam strategy. Think about it. When a surgical scenario mentions a middle lobe resection, you instantly know they're working on the right side of the body. You don't even need the operative report to tell you. Mastering little anatomical quirks like this, it's going to save you so much precious time during the test.
Of course, when things go wrong in those specific tracts and lobes, we run into our high-yield respiratory pathologies. Asthma and COPD, for instance, typically inflame those conducting airways we just mapped out, totally restricting airflow. Pneumonia, on the flip side, targets the deep gas exchange regions, literally filling those alveoli with fluid. You'll also frequently encounter tuberculosis and lung cancer on the exam. Recognizing these pathological terms right off the bat helps you start categorizing the condition properly. And trust me, that drastically narrows down your search in that massive ICD-10-CM alphabetical index.
Okay, so how do we actually link that anatomical map directly to CPT procedural concepts? Let's look at a high-yield term like thoracenthesis. It's like a giant puzzle. The suffix synthesis literally means a surgical puncture to remove fluid. Put it together, and a thoracentesis is a surgical puncture specifically designed to remove fluid from the pleural cavity. And remember, that's the specialized space located just outside the lung tissue but inside the chest wall. When you take a second to understand the word parts and the anatomy, these complex procedural terms suddenly make perfect logical sense.
Beyond just fluid removal, you're going to constantly see three other procedural heavyweights pop up in your coding scenarios. First up, PFTs, or pulmonary function tests. These evaluate ventilation to measure exactly how well those lungs are working. Next is bronchoscopy. This is the visual examination of the bronchi using a specialized scope. Remember that scopi suffix always indicates a visual examination. And finally, tracheostomy, which is the surgical creation of an opening into the trachea to bypass an upper airway obstruction. Here's the key takeaway. Every single one of these procedural codes relies entirely on you knowing exactly where the physician's tools are located in the respiratory tract.
So think of these clinical clues as your ultimate anatomical decoder ring. When you're reading a really dense operative report, you have to translate that clinical jargon into exact locations to nail the right code. Let's practice. If the note says upper airway, boom, immediately think of nasal, pharynx, or larynx issues. If it says bronchi or bronchioles, you want to point your brain toward conducting airway disease, kind of like an asthma pattern. Seeing alveoli or parenchyma, that signals deep gas exchange issues, which means pneumonia involvement. And if you spot pleural space, well, the issue is definitively outside the lung tissue, like an effusion that requires the fluid removal we just talked about.
To tie all of this complex anatomy together into a nice little bow, here's a quick visual summary cheat sheet. It maps out the upper and lower tracts, the lobe counts, and those crucial procedural terms we covered. You really want to lock these locations into your memory to dodge those common exam pitfalls. Having this clear mental map in your head, that's exactly what separates a novice coder who is just endlessly struggling with the index from an expert who knows exactly where to look based purely on anatomical intuition.
You all did absolutely fantastic today. Great job keeping focused on these critical anatomical distinctions. Make sure you practice translating those everyday clinical clues into exact anatomical locations, right? Up next, in part 10 of this explainer series, we are going to conquer the digestive and gastrointestinal system. We'll be breaking down GI tract segments, accessory organs, and endoscopy scope extents. It's going to be a big one. But until then, I want you to ask yourself this. If a single missing lobe can completely alter a respiratory code, how much more complex is it going to get when we tackle the dozens of branching, twisting pathways in the GI tract? Keep decoding, and I'll see you in the next explainer.